Hi, everyone, and welcome back to our next episode of ReWalk's Topics in Neurorehabilitation webcast. I'm Kathleen O'Donnell, and today we'll be talking with the current chair for the APTA Neurology Special Interest Group here in Massachusetts, Heidi Cheerman. Heidi is a board-certified neurological clinical specialist and has clinical experience in a variety of different settings, currently as a per diem physical therapist at the Massachusetts General Hospital Inpatient Department. She also serves as an adjunct faculty member for the Neurological Physical Therapy Residency Program at MGH, the MGH Institute of Health Professions, and the Northeastern University Doctor of Physical Therapy Program. She's also the chair for the APTA of Massachusetts Neurologic Special Interest Group and a member of the APTA of MA Conference Committee. Heidi's talk today will dive into the principles of neuroplasticity and how they help to inform her practice as a physical therapist working with patients with neurological diagnoses. Hi, Heidi. It's great to talk with you today.
Good morning. It's great to be here. It's an honor. Thank you for inviting me.
Awesome. Heidi, I'm personally really excited about this talk because, helping people to tap into the principles of neuroplasticity in order to maximize patient outcomes has really been a huge motivation behind the work that we do with exosuits and exoskeletons. And additionally, this is a topic that's been requested by a lot of our viewers. So, since this is such an important topic to our viewers, I'd love to start a discussion in the comments section below to hear from all of you guys about, the ways that you use principles of neuroplasticity or some examples of exercises that you do that you think really help to tap into these principles so we can get a discussion going in the comments. And please remember to like and subscribe this video if you want to hear more content like this as well. So with that, Heidi, I will let you take things from here.
Great. Thank you so much, Kathleen. I'll start sharing my screen. Okay. So let's start by just discussing, what is neuroplasticity? And it has really been described as the science of how the brain changes, its structure and function in response to input. With that being said, there are really two important aspects when we're thinking about this definition. First, we think about the brain that it can really change in relation to structure and function, unlike virtually any other organ in our body, such as the heart or the liver. Specifically, the brain is really designed to grow new structures and create these new pathways that we look at in the presence of any type of neurological damage in an environment or an environmental challenge. So when we really look at kind of like that second phrase that I mentioned, kind of like in response to input, it really speaks directly to the fact that the brain doesn't really change unless you challenge it. So you really need to challenge that brain in order for change to occur. And you want to make sure that you really be very specific on how you are challenging that brain. So any task that is familiar, and again, that's kind of tapping into the saliency and being more specific, automatic or easy, sometimes that doesn't really challenge our brain. So sometimes we really want to use that to really challenge the brain by using activities that are more challenging and difficult. And this will really challenge and elicit change in the neural network that we're going to talk about. I'm not sure if some of you are familiar with Dr. Donald Hebb, but he is a Canadian neuropsychologist, and he is the one that famously made that statement that neurons that fire together, wire together. So this really means that neurons that communicate with each other ends up being part of the same neural network. And they want to continue to communicate with each other. And this is really when we think about the fact that repetition can be really important when we're thinking about this process. All right, let's talk a little bit more about neuroplasticity. It's really important to point out that neuroplasticity, and as we sometimes hear more simply stated, plasticity, it's not an occasional state, right, to the nervous system. It's really, normally it's an ongoing state that occurs. And this is really because the brain is designed to change in response to the changes in the environment, and not just through injury recovery. So this is a naturally occurring process that happens all the time, and is a normal process that happens, right after from birth into childhood and as we continue to grow. There's a neurologist that some of you might be familiar with, Dr. David Perlmutter, and he had noted that neuroplasticity provides us with a brain that can adapt not only to changes inflicted by damage, but also adaptation to any and all experiences and challenges that we may encounter. So, these changes can occur in anatomy when we're thinking about input that comes into our system, but as well as information that comes out through output. So when we, as physical therapists, when we really consider our treatment environments, this input can occur along afferent connections that come in from the periphery to the central nervous system. So, for example, with challenges to the brain through rehabilitation, with different activities and tasks that we present to our patient and learning a new skill. In turn, outputs from the brain to different types of efferent targets. So that's when we're thinking about the brain to the periphery, really can manifest itself in different ways that allow us as clinicians, as physical therapists, to measure progress. So this is where we're looking at our patients through rehab and trying to ask us questions of, how fast and how accurately, can our patients do this task? All right. So let's talk a little bit and kind of bring us back, brush off some cobwebs to our neuroanatomy here, and think about neuronal firing. Just to remind you guys, this is really the process of normal. So there's the process of normal neuronal firing tasks place a communication between the neurons through electrical impulses and the neurotransmitters. Okay. So when we think about, abnormal neuronal firing, abnormal neuronal firing can occur when the signals between the neurons somehow are disrupted, right? When there's some type of a neurological insult, maybe it was a stroke, maybe the patient had a traumatic brain injury, but basically such a problem commonly occurs in the presence of what we call axonal shearing, as the structure and the connections of the axon is basically shared and it's disrupted. And this basically ends up creating damage to these axons. So basically they don't communicate anymore, with the neurons, and basically that connection is lost. Okay. And that's what happens with our patients when they've had some type of a neurological event. And this basically causes that information basically gets stuck, okay, in their wiring system and doesn't continue. So it can't really be effectively passed on. And, because of this, the input is lost and will likely end up, the neuron basically ends up dying and, can't really establish those connections with another neuron. So the next thing to really think about is, how does neuroplasticity work, right? We really want to look at the cellular level of what's happening. So it's really that process, if you want to think about it, of rebuilding that bridge between these neurons that are disconnected, okay? And rehabilitation, through physical therapy, through occupational therapy, is really that driving force, okay, in this process to really, what we want to do is we really want to be able to provide the right input at the right time and with the right amount of intensity to make these new connections occur. And inside the brain, this basically occurs through four major processes on the cellular level. One is angiogenesis, one is synaptogenesis, which people tend to be a little bit more familiar with in the neuro world. One is called dendritic arborization, and the other one is neurogenesis. Just really briefly, in case you're really not familiar with all of these different processes that occur, angiogenesis basically is the creation of new blood vessels in the brain structures, which, if you can think of, is really critically important when we're working with these individuals who have some type of neurological, insult and damage. So after brain injury of some sort, there can be decreased blood flow, right, to the structures, and when they can be in most need of it. So these structures really need the nutrients, really need that blood, and they don't have it. And they're really in need of it, for more oxygen and glucose for recovery. So, if you want to think about this from a rehabilitation standpoint, it has really been determined that one of the best ways for us to help promote angiogenesis with our neurological patients through physical exercises. Especially, there's a lot of literature out there talking about aerobic exercise and how aerobic exercise can really help facilitate this with this new sprouting of blood vessels. Synaptogenesis is really that creation that we talk a lot about, those new synapses. I think most physical therapists, clinicians are more familiar with that terminology. And this is when you have those new synapses in the brain structures. And similar to the effect of physical exercise and aerobic capacity training with angiogenesis, cognitive exercise is also really needed, to stimulate synaptic growth. So, it's really important to also think about how cognitive challenges also come in along with motor challenges. So just some different things to think of. Also, cognitive exercise also really helps to stimulate that dendritic arborization, which, as the name suggests, is the growth of dendritic spines, which is similar to the branches of the tree that really gathers information from other neurons, which then, from which additional dendrites can grow for purposes of gathering information. And then finally, although there's some dispute as to whether or not the brain actually can grow completely new neurons when you're thinking about neurogenesis, the literature right now does tell us that there are certain areas of the brain that actually grow new cells when we're thinking about that. So just some things to think about there. All right, let's talk a little bit about synaptogenesis, which I think, like I mentioned, I feel like this is a term and a process that a lot of people in the rehab world, especially neuro rehab world, are familiar with, but maybe not into depth. So if you really want to think about synaptogenesis, from the day we're born, during the course of human development, synapses, they're constantly formed, right? And eliminated. And this really depends on whether or not specific neural connections are being utilized. So if the connections aren't being utilized, then they don't continue to form, right? That makes sense. Use it or lose it, right? And that's where that whole idea comes from. So through our early years of development, when we're young, we start off with more connections than we even need, okay? So basically our brains to go through this whole process of pruning, if you wanna think of it like that, we're really eliminating connections that we're not even using. They're not necessary. Through our lifespan after this period of pruning, we really continue to undergo the process of maintenance of available synapses, because there's still synapses that are available, but maybe we're just not using it, right? And we've got to really think about that when we're thinking about recovery and rehabilitation. And that's going to involve both the axons and the dendrites that we talked about. And this process can really require a long period of time. So in addition, longer connections may not be able to regrow in older neural systems. So you kind of think of this is where we're kind of thinking about how age plays a role in rehabilitation with our patients, but may be able to do so in younger brains with excess connectivity prior to that period of pruning. And so that's why our patients who are younger, we say their brains are just more plastic than our patients that are older. Okay, so we're just kind of bringing that, to that form. So reactive synaptogenesis is a process which occurs quickly. And this is really within 10 or 15 minutes and occurs only during a learning task and may not lay down a lasting connection, okay? So it's not something that's gonna be able to be learned over a long period of time. Whereas I spoke about earlier, neurogenesis is a much slower process, okay? And we're kind of, when you're thinking about rehabilitation, the repetition, and requires growing on entirely a new neuron. But how exactly can this be done? And that's a really great question. And that's, right now in research, we're continuing to learn new things about this process. There's still so many unknowns. So again, just kind of thinking about synaptogenesis, it's really that formation of synapses that occur between neurons and in the nervous system. Although it occurs throughout a healthy person's lifespan, as I talked about, right? It's just a normal thing that occurs. It also occurs, after we've had some type of a neurological event, okay? And basically this is just that altered signal transmission that occurs between the neurons. It could be presynaptic or postsynaptic. And also to kind of think about the fact that it can be positive or negative, being maladaptive, which we'll talk about a little bit more later. And it involves, the axonal sprouting, the dendritic sprouting, and also just thinking about other alterations that can occur. Recent studies have provided, strong evidence. I just wanted to kind of think about, I know I've talked a lot about the brain neuroplasticity. I did just want to throw in there for us not to think about, to also, keep in mind that neuroplasticity also happens in the spinal cord the spinal cord level as well. So I think a lot of times, the literature talks a lot about neuroplasticity in the brain, and we talk about that a lot in the clinic. And but there is a lot of research going on right now, thinking about how these same principles apply to the spinal cord. So these studies have really provided strong evidence when we look at locomotor training, for example, with people who have complete or even motor incomplete spinal cord injury. And it's really showing that it induces functional reorganization of the spinal neuronal networks as well at multi-segmental levels, during assisted step training. So I just think it's really interesting for us to think about how cool that is, of how there's also neuroplasticity in the spinal cord, and how we really need to think about how that plays a role with our rehabilitative approaches to these patients. So let's talk a little bit about the forms of neuroplasticity. So when we're talking about that, there are really two most characteristic forms of plasticity that occur within the brain in the presence of some type of a neurological event. The first we think about is really that expansion of the specialized cortical area that we know in the normal brain. Okay, there's an expansion of that. This might be the case maybe with our patient that you have in the clinic who maybe suffered left hemiparesis, maybe after a right MCA, right-sided stroke in the brain. They might be neglecting that left side altogether and really begin using the right side for everything, right? We see this like constantly in the clinic. And this has an effect on basically reducing the cortical area for control of that left side, right? Use it or lose it. While we're now expanding the cortical area, controlling the right side. So this is why, as clinicians in rehabilitation, it's just, especially, in the context of when we're thinking about treating this patient, it's really important for us to stimulate the left side cortical area. Okay, if you want to think about it, we need, use it or lose it, we need to stimulate that area so that if we want to think about it as cortical real estate, for example, it doesn't go away. We want to use that real estate in order to expand these specialized areas to other areas that are functional. So another process of neuronal plasticity also involves recruitment of motor cortical areas, such as a result of injury or new learning. So let me give you a little example of this that might occur in the case maybe of a patient who, I don't know, experienced onset of blindness, maybe as a result of maybe of a brain injury, okay? In this situation, working with this client, in the clinic, the occipital lobe, the area that processes vision, it's no longer receiving input, right, through the visual pathways. And if you really want to think of, practicality, is no longer needed for that purpose, right, because the connections are lost. So you don't need it for that purpose. But, as this patient's other senses come to form, such as maybe they have more of a heightened sense of touch, right? So you're trying to utilize other symptoms more in order to function. This, to a certain degree, this area can then be moved, specialized area, to the occipital lobe. So it's really an exciting and cool process if you think about it. I think it's just incredible to think about, the possibilities and how our brains can transform like that. And I just wanted to show here, Dekoff, Krebs et al., they actually did a study where they did individual differences in motor network connectivity and behavioral responses to intermittent theta burst stimulation. And basically, I think what's really cool about this picture is it's just showing us movements of the affected hand, and you can see movements of the unaffected hand. So on the top, with the movements of the affected hand, we can see the patients. We can also see a control group. So you can see how the left hemisphere is being stimulated with the control group. So this is with they're basically moving their right upper extremity. And in the bottom picture with the movements in the unaffected hand, these individuals are basically doing different activities with the left upper extremity. But I think what's really exciting, and if you look at the movements with the affected hand with these patients who are moving their right upper extremity, you can see the firing in so many different parts of the brain compared to, to this control group. So it really just shows that reorganization of these neural network that occurs in order, with repetitive, specific movements during rehabilitation, in order to help facilitate specific movements. So I thought that was really kind of cool. So when we're thinking about the neuronal remodeling from a treatment standpoint, when you're with your patients in the clinic, methods of increasing neuroplasticity can include, physical exercise, which can be found to increase, different types of neurotropic factors. And if you think about that, it acts as almost like a fertilizer for the brain, if you want to look at it like that. And it also helps to stimulate that angiogenesis that we talked about. So I just wanted to kind of think about that, is that it's not only important for us to do physical training with our patients, but also to really think about the cognitive challenges that our patients also need, and that cognitive exercise can also increase, a specific type of fertilizer, if we want to call it, in the brain, called brain-derived neurotrophic factors, and this basically helps to increase that that synaptogenesis that we want. So, that question really comes up is like, so what if these therapy activities were combined? Okay. And that's when we really think about, for example, maybe you have that person that you're doing locomotor training with, and maybe you have them walking on a treadmill, but at the same time, you have them perform some type of a cognitive activity, right? So that you can, while they're doing some kind of a motor physical activity, they're also incorporating that cognitive challenge, and that really helps to stimulate those neurotrophic factors. on both fronts. So that's just something to really think about there. And then this discussion would not be complete if we did not talk about the principles. When you're really thinking about experience dependent neural plasticity. And I put on here damage to the spinal cord, but this is also damage to the brain, obviously, as well. So Clem and Jones, really help define what are those principles of neuroplasticity. So we've talked a lot about that use it or lose it principle, I think, and we talk about that all the time in the clinic, right? About how those neural circuits not actively engaged in a task performance for an extended period of time begin to degrade. So just something to think about there. So the second principle to neuroplasticity is use it and improve it. So Clem and Jones had really defined that as training that drives a specific brain function can lead to enhancement of that function. So let's just think about an example of this that can highlight that a little bit more. So we talked a little bit earlier about perhaps you're working with a stroke patient and maybe they're presenting with left hemiparesis and maybe they're neglecting to use that side or not using it because it is just really simply too difficult to use it, right? Our patients get really frustrated when they're in the clinic and sometimes they just choose not to use that side at all and use the hand that works better. In the treatment setting, as I think a lot of people think of that, I think we all know about constraint-induced movement therapy. And this can, as we know, is a form of therapy that can be used to really help to restrain the intact upper extremity, the non-affected side, so that the patient is really, more compelled to use that affected limb. So that would be kind of an example of that. Specificity, as Clem and Jones defined it, is really the nature of training specific training experiences. If you think about the nature of the training experiences, it really dictates the nature of the plasticity. When we think about repetition matters, I feel like that's what we hear most, like in the clinic, is repetition, repetition, repetition. And when we think about repetition, it's really that induction of that plasticity requires sufficient repetition. And this is really sometimes the challenge, though, that we face in the clinic is, how do we make this repetition occur and how much repetition is really needed? If you look at a huge body of literature, the literature does show us that when there is high repetitions, that there are significant, differences that we see in people's rehabilitation and their ability to make gains. Intensity does matter, and this is Clem and Jones had defined this as really the induction of plasticity requires sufficient intensity. So the question of proper therapy intensity follows the concept of when we're thinking about repetition as well. So, here there's still so much research going on about thinking about like what is the proper dosage that is necessary, because there's this literature that shows these really high repetitions, but is there a sweet spot somewhere that's less than that we can that's more applicable and that can occur more in the clinic, and really thinking about like how many sessions and all those different things that there's more and more research on. Time matters, so really thinking about different forms of plasticity occur at different times during recovery. So the principle is really based on that idea that after an injury, the brain really wants to recover. It's just actually a natural process that the brain wants to do with that synaptogenesis. So it makes sense that the earlier you provide the opportunity for recovery through these neuroplastic changes, the better. And this is really when we start talking about the early versus the late approach, especially important, really, when you think about the support that happens at the beginning of your treatment before we end up having those maladaptive behaviors that we don't want to occur. Salience matters, and this is Clem and Jones define this as that the training experience must be specific, specifically salient to induce plasticity. Also, I think we, most of us kind of realize at this point with all the literature and working in the clinic, anecdotally, that age does matter. Training induced plasticity occurs more readily in the younger brains. But with that said, our older population, the research has shown us that they still have, plasticity, and they still have the ability to have neuro recovery. So I think we do need to keep that in mind. Transference or generalizability, Clem and Jones had defined as plasticity in response to one training experience can enhance acquisition of similar behaviors. So that's kind of that transfer of a particular skill to another and trying to make that generalized. And also, the last principle is really thinking about interference. And that principle, as Clem and Jones talked about, was plasticity in response to one training experience can impede acquisition of similar behaviors. So something to kind of think about there. That is also included. So there's so many different principles here, and I think the most important thing is to try to make this most applicable when we're working with our patients in rehabilitation, is to really think about what's most important and what can you tap into the most in order to help optimize neuroplasticity. I hope you all have enjoyed the talk so far today. I know we went down to kind of like that cellular level, but I think it's really important to kind of think about what is happening on a cellular level, because, it's really important to understand that what we do every day from the moment that we step foot and we're working with our patients can make a huge difference in their neuro recovery. And we play such a huge role with that. And I think it's really exciting just to kind of look at all the, exciting things that are happening with research. So, in summary, plasticity of the brain really serves to support learning. And by utilizing these inherent capabilities, physical therapists or anyone in the rehab world, other clinicians can enhance recovery from brain injury as well as spinal cord injury. So we're thinking about neuro as a whole by really trying to apply these principles of neuroplasticity directly to our treatment, every day in some way, shape, or form. So thank you so much for joining today. Thank you for this opportunity. It was a lot of fun.
Thanks, Heidi, for such an in-depth presentation. One of the things that I really enjoyed about this talk is how deep you really dig into, the underlying biological mechanisms that help to explain the, pretty amazing power of the brain to reorganize and relearn. But I think what you did a really nice job of is continuing to circle back to what this actually means in the clinic and what this means for physical therapists as they're treating their patients. So I just wanted to ask you a few more questions about that. And the first one, I think, we always think about neuroplasticity as being, such a beneficial thing and that it's so great, and it is. But you also raised a really important point about the concept of, maladaptive neuroplasticity and the potential for patients to learn or develop unwanted behaviors or movement patterns that are potentially going to be difficult for them to unlearn. So I was wondering if you could expand a little bit more on some of your strategies for how to establish and reinforce those good movement patterns with your patients, and try to, get in before those compensations develop that might be more difficult for them to unlearn in the future.
Yeah, thank you so much. That's a really great question, Kathleen. So one of the strategies that I'll use the example of really thinking about gait training and locomotor training, for example. So, with a lot of my patients, I think it's a good start for initial task analysis to start in the parallel bars, for example. It's a great place to just start to kind of really get an idea of how your patients are moving and how they're utilizing the body and the areas that they're really challenged with. And it also obviously provides a relatively safe environment for our patients. However, with that being said, when you're really tapping into neuroplasticity, I think it's important to try to get our patients out of the parallel bars as soon as possible. So I really try, if my patients that are appropriate, is really to get them, into like body weight support. for example, treadmill training or over ground. And this is because if you think about the parallel bars, for example, patients tend to have a real heavy reliance on their upper extremities, right? So they tend to like really rely on their upper extremities. They're not really putting as much weight bearing into their lower extremities. And also patients have a tend to want to pull with their upper extremities. So especially if they have one side that's more intact, they might be like pulling themselves over to that strong side, again, not shifting their weight into the weak side. In that parallel bars, patients tend to have more of kind of like that flexed posture. It can promote more asymmetry. And really overall, there's really a less demand for balance control sometimes. So if you think about it, parallel bars are a great place to start sometimes with our patients with walking, doing gait training. However, it can really promote bad neuroplasticity, that maladaptation, if you want to think of it. So something that I use in the clinic is really to try to get them out of the parallel bars as quick as possible. And a great way to do that is with the body weight support training, especially over the treadmill if it's appropriate. So that way you're really getting more weight bearing in someone's lower extremity. You're decreasing that heavy reliance on their upper extremities, and you're just really able to tap into that neuroplasticity more. So that would be an example of how some way that I utilize that in the clinic.
Definitely. So trying to progress them toward the desired behaviors, as aggressively as safe and as possible, sounds like.
Yeah, exactly.
Great. I definitely really appreciate that you went through all the 10 principles of neuroplasticity by Clem and Jones. And I'm curious about your take on kind of the first one, which is the time matters. Because, I think sometimes we sort of get this idea that, okay, we're past that window of recovery and that's all we're going to get.
Yeah.
So I'm just curious what your what your feeling is and what the latest recommendations are in terms of, timelines, particularly post-stroke. Do you feel like there's, really a window? Is there too early or too late? Or how do you really approach that?
Yeah, so that's a really great question. So, I mean, there's still, a lot going on in research right now to really specifically define it. However, with that being said, with the body of literature that's out there, really the, neuroplasticity or that kind of like change that takes place for neuro recovery happens right off the bat after someone's had a neurological level of injury. So it's really important that, the literature is showing us that early mobility is safe. So, mobilizing patients early on after any type of a neurological event, such as a stroke and a brain injury or spinal cord injury, it's best to get them moving quickly. But with that being said, you in regards to the actual principles of neuroplasticity, you have to be cautious because in regards to that too early phase, that anytime anyone's had any type of a neurological event, there's a lot of different things that happen. There's a lot of edema and swelling metabolically. There's a lot going on within that, first week to 2 weeks of that inflammatory phase. So the literature is showing us that although it's really important to have early mobility, that some of the application of the principles, like for intensity, for example, it's really safer and best to kind of hold off on really intensifying treatment until after that acute period of 1 week or so after someone's had a neurological event. And in regards to kind of finding that sweet spot, literature has really shown us that the brain has the ability for neuro recovery with plasticity greatest within 1 year after any type of a neurological event. We've just seen that, patients are able to, those connections are going to occur most within that time frame. So really, really within 6 months to a year, we really want to utilize that time as effectively as possible. And, the literature does show that after that year, post neurological event, there seems to be a slowing down of neuro recovery. These patients who have more chronic neurological insults, they still do have the ability to make change. So, the sweet spot is really is within that 6 months to a year time frame. Although we do need to keep in mind that our patients that are more chronic in nature after a year do have some ability to make positive changes for neuro recovery.
Great. And you actually mentioned some of the other principles, and I think again, I just want to kind of dig back into some of the other principles that you listed.
Right.
Obviously, as a physical therapist, there's nothing you can really do about the age of your patient or some of them. But what are some of the examples of ways that you try to incorporate these principles into your practice? Perhaps specifically focusing on things that are within your control. So perhaps the specificity, the repetition, the intensity, or the salience of those exercises. How are some ways that you would incorporate those in your practice?
Yeah, thank you, Kathleen. One thing I really do think about is task repetition. And I think it's really important that we think about not only repetition within our session, but outside of our session, right? So when we're thinking about repetition, we have to think about the big picture here. And so clinically, how I think about increasing repetitions is how can that, if I'm trying to work on a specific task or a behavior motor-wise, how can I make sure that these movements are also being performed by maybe other healthcare providers. So if I'm working with my patient in the hospital, I may talk with the nursing staff about a specific way that I want my patient to transfer. I mean, collaborate with occupational therapy about, certain strategies that I'm using with this transfer. And, also when it's appropriate, doing family training as soon as possible with certain tasks so that we can start to get the family involved so that patients are doing tasks outside of my session, or if they're patient that's an outpatient and they're at home, really trying to think about how can they perform these tasks with increased repetition at home and outside of my sessions. So that's an example there with repetitions. In regards to thinking about saliency, working with, when you think about salience, working with patient population, I think it's really important that we all really get to know our patients, like who they are, and, really understanding like what makes them tick, right? And understanding what is going to drive our patient, what's going to drive them from a motor perspective, what kinds of activities are they not only familiar with, but what kinds of activities do they really love that is hopefully even with their neurological insult will help trigger kind of like a stronger connection to make them want to move. So, I mean, an example of this that I had myself was, I had treated a patient at Mass General Hospital, an inpatient who had sustained a traumatic brain injury, and he just didn't demonstrate any initiation of movement, and it was really challenging for me to facilitate that. But through discussions with his family, I had learned that he was really an avid basketball player, and he loved watching the game. So I had his family bring in not only a basketball, but the basketball had been signed by a bunch of NBA players. And so, and I guess he felt really connected to this basketball. And so what I did was I used it during my sessions and kind of started placing it out of reach for him. And it was like kind of incredible actually, because I couldn't get him to move anyway. And then all of a sudden this ball comes in and it was like a really cool color basketball too. And it had all these names on it. And all of a sudden he started to try to move towards it and really tried to help drive him to move. And then he started kind of manipulating the ball. And then as we progressed, I really, utilized that ball, for passing and throwing and using it for, different things with targets, to really just challenge him on many levels. So I think that's a really good example when you're thinking about salience, utilization and, during our rehab sessions. So, yeah.
Absolutely. All right. And then lastly, just for any of our viewers who want to learn more about neuroplasticity, what are some of the resources that you might recommend for them to get started?
So a really great website, I think, if people just want to start, there's a website called positivepsychology.com, and they really do a nice job, actually, of just going through like the whole history of neuroplasticity, what it is, how to utilize it, and they also provide you with a lot of different articles and books that you can use for resources. If you're really interested in the topic, I know the summit of professional education has like a neuroplasticity and neurological disorders course, if anybody was ever interested in looking into that. Also, the APTA, American Physical Therapy Association website, especially if you are a member, it's a little bit easier to get access to certain things. But the Neuro Special Interest Group on that website has a lot of different articles and information on neuroplasticity, and also the Journal of Neurologic Physical Therapy has a lot of articles to gain some information. And then there's a lot of research. I think a lot of people are familiar with Dr. George Hornby, who is a professor of physical medicine and rehabilitation at Indiana University of Medicine, and he's also the director of the Locomotor Recovery Laboratory there. So I'm sure you're obviously very familiar with him. But if you really Google him and neuroplasticity, he's done a lot of different work with neuroplasticity, and there's some really great resources and information that you can get through his work.
Excellent. And we'll actually include links to all of those resources that Heidi just mentioned in the video description below. So if you want to check those out, go right ahead. Well, Heidi, thank you so much for a great talk, and thank you so much for your time. Really appreciate you taking the time to speak with us here today.
It's great being here. Thank you so much.
And to our viewers, we hope you've been finding these talks educational and useful. So don't forget to reach out in the comments section with examples of how you use the principles of neuroplasticity in your own clinical practice. What are some activities that you think are particularly successful in addressing these principles? And what are some principles that you feel are a little bit more challenging to apply? And maybe we can get some conversation going to help you out with that as well. So we'd love to hear from you. And please make sure to like and subscribe to this video using the buttons below. And feel free also to use the comments section to suggest any future speakers or future talks that you want to hear from us. Hope you tune in again next week, and have a great week, everyone.